There have been very few elderly-specific trials. I did mention one yesterday, which was GOG 273, which is the first study of in gynecologic oncology of older women with ovarian cancer, and it uses as a data issue the geriatric assessment, which is put forth by the Cancer and Aging Research Group, and that study showed that very simple geriatric parameters are better than clinical judgment in assessing and predicting which patients will tolerate therapy. Now, it has to be validated in various patient groups, and one of the patient groups that's being validated in is this GOG study, which uses Taxol and carboplatin in the adjuvant or neoadjuvant treatment of women over the age of 75 with ovarian cancer. So that's probably the most important study in terms of elderly specific, at least in the US. The other issues are really not so specific geriatric, but only in the sense that most of the patients who will get these diseases are older. That's why there's SIOG. But it looks like targeted therapy is going to be, or is becoming the big issue in terms of treatment, and whether it's breast cancer, lung cancer, colon cancer, renal cell, or melanoma, either this targeted or biologic therapy. Has been unfortunately in the last decade or so, there are very few older patients on these studies. Even the studies that have been utilized to get these drugs approved through the FDA. There have been editorials and things written over the years about that particular problem. It's still a problem because clinicians facing an older patient, let's say 80 plus or even 75 plus, they have to figure out how to treat these people. And the data that's in these studies really doesn't help address that. So we're still kind of extrapolating. So that's really been the big issue, is how to incorporate these targeted and biologic therapies into treatments for the older patients who aren't participants in the clinical trial. I think the other big issue is this genomic analysis studies. It started in, at least the ones that I'm most familiar with, was started in endometrial cancer, primarily because, well, one of the reasons is one of the principal investigators is at our institution, who's a gynecologic oncologist, and his laboratory has been focusing on endometrial cancer, and one of the things I showed yesterday was studies of these genomic analysis trying to differentiate various histologies of endometrial cancer, less aggressive to more aggressive, to try to make predictive models and to figure out the most appropriate treatment. The other thing is we're looking at markers, genetic markers in various types of gynecologic cancer, and I think this genomic analysis is going to be applicable to patients in general, but even to older patients, because obviously they're the ones with the diseases. So I would say that's one of the other big issues. The other thing that I did mention was, unfortunately, fortunately, we have to discuss cost. I think we can't ignore that issue. There's been tremendous controversy, particularly in the US, about cost of medical care. And these newer drugs are tremendously expensive. It's not unusual to have a therapy that's $6,000 to $10,000 a month. So who's going to pay for that? It's all well and good to have this great science and great technology, biology, but if your patients can't get it, it doesn't. So access to care is a big issue. I mean, the patients are seen by physicians, but then you're confronted with the idea of these expensive therapies. And personally, I face this issue every single day. Patients want therapies that they see and they hear about, but then it's very difficult for them to get it, particularly in the US in Medicare. People over the age of 65 may not have a drug plan associated with their Medicare, and so there's a lot of out-of-pocket expenses. So I think that's also a very, very big. So cost of care, access to these new technologies is a very, very important issue. We don't really know that yet. I think the data of these genomic studies are just emerging. So we really kind of don't know that. There may not be, actually, but we still really don't know. The other thing about the genetics issue is, these genomic studies, these are, for the most part, these are not inherited abnormalities. These are tumor-acquired abnormalities. But in the other aspect of genetics is, in gynecological cancer, a lot of the diseases are genetically related. Ovarian cancer and endometrial cancer, there are various syndromes, the BRCA1, BRCA2, and in endometrial cancer is the Lynch syndrome. And we really look very carefully at patients because family history is very important there, and advice we could give to families. And that's really not an age thing. I mean, a lot of people think of BRCA, they think of young women, but I've seen a number of patients in their 60s and 70s who just found out that they were BRCA positive. And when their older siblings were tested, were also BRCA positive. And we've done prophylactic surgery on them, and lo and behold, we found cancer. So these are real issues for people of any age. And what we do is, particularly in ovarian cancer and serous cancer, we do genetic testing on everybody. And that's irregardless of age. So, and we're finding issues in older patients too. Because if you're 70, you have children and grandchildren. Wouldn't you want to know that? You could prevent cancer in 2 generations by finding that out. So while it may not be so important, but it really is to an older person, but they want to know, and that's like a big thing. You could prevent cancer in multiple generations, or at least make a plan of fertility or something with your daughters, children and grandchildren. So it has a lot of implications. What we do, as opposed to many institutions, we do not have, people always ask me that, we do not have a geriatric oncology clinic. And I think the reason is we're a cancer hospital. And the feeling of the institution when these things were set up, and I didn't personally set them up, but I'm very involved in them, but when these things were set up, it was really the idea that cancer, the older people are the ones who get cancer. And this whole thought process about aging and how to take care of older people should be throughout the fabric of the institution. You know, why should you have to refer a patient to the geriatric oncology clinic if they're 75 and they need surgery? So what we've been doing, so it really creates more of an environment that the institution, people work there know that this is an issue and this is part of an evaluation process. So for instance, virtually every new patient to the institution who's over 70 or 75, I forgot exactly the criteria right now because it's changed a little bit, gets a geriatric assessment. Virtually every pre-op patient gets a geriatric assessment who's over, I think, 75. So it's just part of the process. And because of that, I think we've raised the level of care for all the patients. They don't have to be specifically referred to the geriatric oncology clinic. There are people in various disease management teams, for instance, like GYN oncology or lymphoma or colon cancer, who do have special interests in older patients. But by creating an environment where people just know that's an issue, we don't have to have that much specificity. You just know this is part of an evaluation. So whether you're being seen by the sarcoma service or the breast service, this is part of your evaluation. The nurses do it. We have pre-op assessments. I mean, Memorial is one of the few, if not the only, cancer program in the U.S. That has a geriatrics division. And actually, our chief is here at the meeting. So I actually don't think there's another cancer center that has a geriatric division the way ours is. Now, the 65+ program, what it does do is we meet monthly. We plan educational programs. Various projects are planned, but throughout the institution, such as occupational physical therapy, psycho-oncology, social work. So it's a group of various modalities, again, and the physicians are one of them, but all these subgroups, like I said, nursing, social work, occupational therapy, physical therapy, psychiatry, pain management, and we all meet and we just go over what's going on in the institution, how we could make care plans better, how we could provide educational services for the people in the institution, and we do a lot of outreach to the community, because Memorial actually spreads pretty far and wide from the main campus. It goes throughout the New York metropolitan area. So it really, its catchment area in a sense is 25 million people. Obviously their market share is nowhere near that. They couldn't do that, obviously. But the people we see throughout the institution have advantage of all this type of expertise.